Pichare. I am from TYBPT and my topic for rubric 3 is clinical features and radiological findings of prolapsed intervertebral disc. First of all, introduction. The spine is subjected to stress that results from disc degeneration and spondylosis. Disc degeneration may lead to lesions that can damage to the spinal cord and its roots. Lumbar disc herniation is a common low back disorder. The herniated disc is a displacement of a disc material beyond the intervertebral disc space. The herniation process begins from the failure in the innermost annular rings and progress radially outwards, also known as prolapsed disc. Now, clinical features of PIVD. The patient is usually an adult, aged between 20 to 40 years of age, with a sedimentary lifestyle. The commonest presenting symptom is a low back pain with or without radiating pain to the back of the leg, that is sciatica. A preceding history of trauma is present in some cases. In few cases, there is a history of excretion, such as that the patient has lifted a heavy weight and pushed a heavy object, pushed something immediately, preceding a sudden onset of backache. Now, first is low backache. The onset of backache may be acute or chronic. The acute backache is severe with the spine held rigid by the muscle spasm, and any movement at the spinal is very painful. The patient may be able to go about with difficulties. In extreme case, he is completely incapacitated. Any attempted movement producing very severe pain and spasm. In chronic backache, the pain is dull and diffused, usually made worsen by any excretion in sitting and standing for a long period of time. It is relieved by rest. Now, sciatica. Sciatic pain. It is usually associated with low back pain, but may be the sole presenting symptoms. The pain radiates to the gluteal region, back of the thigh, and the leg, and the pain radiation depend upon the compression of the nerve roots. The S1 root compression, the pain radiates to the posterior lateral calf and the heels. The L5 root compression, the pain radiates to the anterolateral aspect of the leg and the ankle. In a disc prolapse at a higher level, that is L2 and L3, etc., the pain may radiate to the front of thigh. Often the radiation may begins on walking and is relieved on stress. Now, neurological symptoms. Sometimes the patient complains of a paresthesis, most often described as a pins and needles, corresponding to the dermatom of the affected nerve roots. There may be numbness in the leg and the foot and a weakness of the muscles. In case with a large disc material compressing the theca and the roots, coda equina symptoms results, where the patient has irregular LMN type paralysis in the lower limb, bilateral absent ankle jerks with hypoesthesia in the region of L5 to L4, dermatomes, and urinary and bowel incontinence. Now, the radiological findings of PIVD. First is X-ray. It does not show any positive signs in case of acute prolapse. X-ray are done basically to rule out, means to find out any infection in the spinal cord. And in case of a chronic disc prolapse, the affected disc space may be narrowed. Means here you can see. Here you can see the space is narrowed. Now, in CT scan, normally in an axial cut section, the posterior border of the disc appears concave. In case where there is a disc prolapse, it will appear flat or convex. There will be a loss of a prethecal fat shadow normally seen between the posterior margin of the disc and theca. The herniated disc material can be seen within the spinal canal pressing to the nerve roots or the theca. Now, the MRI scan. This is investigation of a choice. It shows the prolapsed disc, theca, nerve root, etc. very clearly. Now the electromyography, that is EMG, finding of a denervation localized to the distribution of a particular nerve root, helps in localizing the offending disc in case with multiple disc prolapse. This test is rarely required. Thank you.